Good morning, everyone. Thank you very much for joining us today. The topic of discussion, and you will see the title of my talk is ever so slightly different to the title of the seminar. And that is really because medical errors are just a small part of adverse medical events. So most of us are familiar with scenes like this. This was splashed all over the media on a number of occasions in the last 2 years. And this is obviously something we do not want to be seeing. We don't want to be seeing doctors being locked up, being put in the back of police vans. So what's the problem with our current system? You know, is there some kind of an issue that's leading to all of this? Why are there arrests taking place? Why are we seeing inflammatory media headlines like this? And even more, and you've probably heard recently, why are we seeing incomprehensible murder charges against doctors who are obviously not setting out to deliberately injure their patients? We understand things can go wrong, but murder implies some degree of intent. So how did we get here? Obviously, there has to be a trigger to the whole process. Something has to motivate, and typically it starts with the patient experiencing an adverse event, but that on its own is not enough. What motivates the patient to take this to the next level and to get to the point where maybe criminal charges are instituted? Often an injured patient feels abandoned and very often angry. Something has happened to them quite unexpected. But what makes it worse is what happens after the injury. If you think about it, for the most part, we share the same mission statement as our patient. We want to make them better. They want to get better. It's really, we're on the same page. And even when something unfortunate happens, we remain on the same page. We want to see them through. We want to fix them. Of course, if that adverse event has resulted in death, then that's not possible. But then we owe the family, we owe the people that have succeeded the patient, we owe them some kind of an explanation so that they can get closure. And often this is what the patient really wants. If you dig into patients after they have been involved in an event, they don't talk primarily about money. They talk about closure. They want to know what happened. They want to know why it happened and what the next step is. They want to know that there's some degree of accountability in doctors. And they want to know that we are learning from our mistakes, that these mistakes are not going to affect other patients, that retraining will take place when that's required. So, what are the patient's options for recourse when they encounter an adverse medical event? Typically, there are 3 pathways, and these are separate pathways which normally flow sequentially, but can flow concurrently. So these can all happen at the same time. Typically, after the event, there is some kind of a professional process, an inquiry, a complaint, a question and answer session, and sometimes it triggers a formal inquiry, which usually falls under the gambit of our professional regulator, the Health Professionals Council. Then, and not always after that's concluded, but often once it's concluded, if there is found to be some degree of negligence, then a civil claim is instituted. And this is basically a private way for the patient to seek some kind of compensation from the people responsible for the error. Of course, some errors have no particular person responsible. It's just something that can go wrong, as in a complication. And some are multifactorial. And so it's not always as easy to figure out who exactly to blame. And finally, and very uncommonly, although we are seeing this more commonly, are criminal charges. So what are we aiming for? Basically, we're aiming for a safe, error-free environment. We want patients to be able to not have any complications. We want everything to go according to clockwork. That's the perfect world. Unfortunately, that's not the world we live in, and you'll see why just now. If that does not happen, and if there is a complication, an adverse medical event, what people used to call medical misadventure, then we want patients to be able to have access to the appropriate treatment and, if it's necessary, the compensation for their injuries. We need a system, ultimately, that fosters closure for the patients, that fosters accountability in doctors, and again, that fosters learning from mistakes. So let's recap. What are the problems? What is the extent of the problem? And I'm going to talk about this now. First and foremost, we have seen over the last few years how compromised the doctor-patient relationship has become. And this is for very many reasons, but primarily it's a capacity problem. If we had all the time in the world, we would be able to be as thorough as possible. We would make far fewer mistakes, but we're all under pressure. The public system is under pressure because it lacks the resources. The private system is under pressure because it's constrained by the funding mechanism. So you've basically got to make your time valuable. Secondly, there is no clearly defined patient complaint pathway. So yes, there's recourse with the Health Professionals Council. Yes, you can report a problem to the manager of a facility. Sometimes that's the person that's been responsible for the problem, to a hospital group and the like. But there's no clearly defined singular patient complaint pathway. And the legal framework is really problematic. Ultimately, when something goes wrong, it's a systemic problem. It's often not just one thing that went wrong. So how bad is the problem exactly? To err is human, and there is a book written in 2000 that sheds an incredible amount of light on this. Basically, the book was based on the findings between two separate studies done in Colorado and Ohio, and another study done in New York hospitals that showed that medical error and adverse events are uncomfortably frequent. These things happen incredibly more often than we would like to admit. They found that between 2.9 and 3.7% of all admissions experience some kind of adverse event. Just process that. 3%, 3 to 4%. They found that of those that experience an adverse event, between 6.6 and up to 13.6% of those resulted in death. The patient died as a result of that event. And they found that about 50% of them were plain, simple, and utter mistakes, not complications. A separate study done and published in the British Medical Journal was a study coagulating 8 studies put together, basically looking at 75,000 patient records and looking at the clinical records and what had happened. And they found that 9.2% of these admissions had an in-hospital adverse event. Just imagine that, 1 in 11 patients. And that the preventability was up to as high as 43.5%. So again, almost half of these patients, these errors could have been prevented. Fortunately for the patients, more than half of them resulted in no or very minor disability, 56%, but 7.5%, 7.4% of these errors were lethal. They killed the patient. The most common problems were about 40% due to operations, and 15% of these errors were medication errors. These are all completely preventable. So the result, of course, is that we landed up with what's become a litigation circus for lawyers and insurers. It basically has created an entire industry out of this medical misadventure. And as a prominent orthopedic surgeon in the UK said to me, unfortunately, it's in no one's interest to stop this system. Or is it? Actually, if you think about it, it's in our interest, and it's most definitely in the patient's interest to stop this system. As doctors, we often pay huge amounts of money to insure us against medical malpractice. A small amount of that money ultimately reaches the patient that's been the victim of those misadventures, and a huge chunk of the money gets used up between the insurance companies and the lawyers. There is also a problem in the whole legal framework. In most countries in the world, this system is adversarial, automatically pitting patient against doctor. Who created the problem, and then they must pay. They must somehow compensate. They must somehow compensate the patient. Of course, this in our own particular setting has not been helped by the regulator. The Health Professionals Council has for some time been accused of being quite dysfunctional and very tardy. Very seldom do they offer the patient the closure that they are looking for. Ultimately, this all leads to unhappy patients. So what happens after a medical misadventure? There is no standardization of complaints pathway. there is differing advice given to the doctor who is responsible or who is involved or who is in charge of the patient's care, differing advice coming from the insurers versus the profession itself. There immediately is set up a situation of divide and conquer. And of course, that's not good because it pits the facilities where these errors take place against the doctors who work in those facilities. And that's really not good. And ultimately, it's not good for the patient at all. And the ultimate result is that the patient is left again without closure. Sometimes they are left without a decent result, and sometimes they are left with inadequate compensation. So, are we our own worst enemy? What's happened to medicine? We really need to ask some philosophical questions here. We need to dig a little bit deeper into what's going on with us. Many years ago, maybe not that many, 20 or 30 years ago, medicine was a very highly respected profession. Doctors had a high standing in society as ethical, honest people. Why is that no longer the case? Why are people questioning our decisions and our advice so frequently? We've seen this classically throughout the coronavirus pandemic. Are we our own worst enemy? Is this because of the lack of transparency coming from the medical profession? The fact that we don't admit how often we don't know the answer? The fact that we don't even have clear statistics on just how good we are or aren't at treating something? Do we lack honesty? And of course, with the advent of the internet, people have access to information that's far more ready than it was in the past. Google Doc has become a thing. And so the problem, of course, is that you land up with memes like this. Please do not confuse your Google search with my medical degree. But of course, there are flip sides to that coin. Patients sometimes understand much more about their condition than we do. Certainly, they understand the subjective side. And what ends up becoming our role is not always to give them information anymore, which they often have. It's to help them contextualize that information and to help them make a diagnosis. Because as we all know, self-diagnosis is not necessarily the case. Of course, there's a degree of media culpability here. And I think in the public, there's a degree of schadenfreude. They actually, the media and the public like to see someone successful with a good standing go down. This is bad for us. Bad news sells. Sensationalism is destructive. And ultimately, we get alienated by the media. This is not good. How many articles have we seen? How many newspaper reports, television programs? There's even a series called Botched. The name implies the answer. We need to work against this. We need to reclaim some of our space. Of course, accountability is paramount. We cannot step back and not take accountability. But there are many different spheres to this accountability. In the UK, they distinguish between negligence and gross negligence, and this is very important. Maybe there needs to be a second, third, fourth, and fifth degree of negligence. Clearly, there's a difference between forgetting to prescribe something and amputating the wrong limb. These are massively different things. Peer review systems, these need to be done by the people who actually really are important, who can work out what it was that went wrong and implement that change that is necessary. It is no good that a panel of general practitioners looks at what went wrong in an orthopedic surgery and try and figure out how it went wrong. And even worse still, which is the problem with our Health Professionals Council, that a panel of accountants and lawyers look at the same thing. They're even less able to understand the management. Maybe we need to move towards a system where we have a safety management system, things that look at the kind of Swiss cheese process and try and put in these different slices so that the patient doesn't fall through lined up holes. The aviation industry is really the way forward in this, and we need to close the loop and implement change. So ultimately, what are the recommendations? How do we fix this? I have 4 simple suggestions. I'm not saying that these things are going to be easy. This is going to require massive systemic change. But here are 4 recommendations that really can massively change this space. We need to create a no-fault compensation fund. We need to stop blaming people because that doesn't fix the problem. We need to work out what the patient needs. We need to explain to them what went wrong or to their relatives, and we need to make sure that they are taken well care of after this. Undoubtedly, the world pinnacle of this is the New Zealand Accident Compensation Corporation. It was started in 1974, and there have been a whole lot of changes, but since 2000, they have incorporated medical misadventure, which is now referred to as adverse medical events or medical injury. It's a separate department of this corporation, and the patients are taken care of. We need perhaps to create an independent patient complaints agency. Patients have no voice, they have no recourse, they don't know who to turn to. They turn to our regulator, whose job is to police, and they often get a response, no, we cannot find any culpability or liability here. That's not an answer. They need to be able to communicate transparently and bilaterally with the team that was responsible, under whose care they were when this misadventure took place. We need to formalize our peer review processes, and this needs to be done under the banner of the Medical Association. We need to lead this process under the specialist societies, under the societal groupings of general practitioners, and we need to look after our own colleagues. We're the only ones who can really independently work out what is a good result, what is a bad result, what is acceptable, what is unacceptable. What do we do with a colleague that's made the same mistake several times? Can we retrain them? And so on. And finally, we need to make mediation mandatory. We need to stop fighting with each other. We need to sit down and discuss what went wrong. We need to be able to sit, even if the lawyers are involved and the insurers, but that industry might die if we actually get this right. We need to be able to sit down with the patient and or their relatives and explain exactly what went wrong. If we do that, we will stop the complaint system that's resulting in people trying to get doctors jailed for making a mistake or having a complication, which is something that can happen to any single one of us. I thank you very much.